Hi there. I'm Kyle McGivern. Some of you may know me on here, some of you may not. We decided to do a webinar to try to get some information out about joint replacement, specifically knee and hip replacement, and answer any questions people might have, save them an office visit, especially during COVID. It's nice to gather information without not having to get out and about. So we'll go ahead and get into it. A little bit about me. Born and raised in Oklahoma City. Went to the University of Oklahoma for undergraduate. Moved out to Blacksburg, Virginia for medical school. Came back for residency in Oklahoma City, and then did a fellowship in Florida. I returned here to start practice. I've been with Doc specifically for 2 years. Was part of their launch in the Oklahoma City market, and I'm excited about the future that we have here. So kind of running through some topics that we'll be discussing today. I want to understand what joint pain is and what causes it, discuss some different treatment options, obviously specifically talk about joint replacement surgery, some expectations for recovery, and then as Kylie said in the beginning, we're going to answer any questions you might have at the very end. So throughout the presentation, if something comes to your mind, go ahead and drop it in the Q&A box, and I will go over as many of those as I can at the end and answer any questions that you might have. So obviously our joints are involved in everyday activity from the moment we wake up to the moment we go to sleep. An injured hip or knee that hurts can severely impact your ability to do what you want to do, to move, work, and play. Common causes of joint pain, if we're focusing specifically on arthritis, there's rheumatoid arthritis or different types of inflammatory arthritis. And these are inflammation around in the joint capsule that can deteriorate the joint and cause pain. There's osteoarthritis, which is by far the most common. And that is just wearing down of the cartilage cushion in your knee, and it causes bone to rub against bone. So that's what you typically hear people say is I have bone on bone arthritis. And that's when it gets to an end stage and really starts to hurt all the time. There's also post-traumatic arthritis, which is far less common, that happens after an injury. Maybe, at 40 years old, someone had a car accident and broke their tibia into the knee joint. And then later on down the road, their knee develops arthritis a little quicker than it normally would because of that injury. Going through some non-surgical treatment options. Obviously, any of the ambulatory aids like walkers and canes can help you put less pressure on that joint, but are kind of cumbersome to lug around and affect your lifestyle. Hot or cold therapy, typically that's in the form of cold therapy, can relieve some pain at the end of the day when things get very swollen. Physical therapy, depending on the etiology of your pain, there are things with physical therapy that can help with posture and the way that you walk or your gait to help alleviate pain. There's over-the-counter and prescription anti-inflammatory medications. You hear them called NSAIDs. They're ibuprofen, naproxen, meloxicam, Celebrex, all those sorts of things are all anti-inflammatory medications that we can use. And then there's different types of injections. Whether that's your typical steroid injection that people call a cortisone shot, whether that's a viscose supplementation or lubricant shot, or some of the regenerative medicine therapies like PRP, which is platelet-rich plasma. The big question that people have is, when do I consider joint replacement? And there's, this is a pretty good little checklist of things that if you check all these boxes, it makes sense. Does it affect your ability to get a good night's sleep? That's important. Obviously, you don't have a very good day if you don't sleep the night before. Does it keep you from doing things you want to do? If you like taking your dog on a walk and it hurts too bad to do it, and you notice that you're not going out and doing that, maybe you should change something. Are you less active because of your joint pain? That kind of goes along with the previous, but a little different line. And then, is it affecting your ability to walk upstairs? I think that people that have painful knees and hips really notice every stair that they encounter, whether it's walking to work, walk into the library, walk into church, any of those sorts of things. Kind of focusing on hips to start with, I do an anterior total hip replacement. We'll kind of go through some of the benefits of that and what that means. If we're looking just the basic anatomy of the hip, the hip is a joint comprised of two bones. One is the socket, which is part of the pelvis, and the other is the femur, which has a ball. So it's a ball and socket joint. And that's a pretty good depiction there of what a healthy hip should look like, where you have nice white cartilage covering the bone on the femur and in the socket, and then a diseased femoral head where that cartilage is starting to wear down. And that's highlighted right there. This is an X-ray form of what a normal hip should look like. The ball's nice and round, you have good space there, and that's an arthritic hip, fairly severe, but a good illustration of the ball's not quite sitting in the socket right, and the bone's touching the bone, which is obviously going to cause pain. So how does a total hip replacement work? There are several parts. One part replaces the socket, which is the cup. The other part is a stem that goes inside the femur. And between those two, there's a liner that goes in the cup and a ball that goes on that stem. And that recreates a new ball and socket joint and prevents bone from rubbing on bone. There's over 300,000 total hip replacements performed in the US, and that's data from probably about 5 years ago. So the number's steadily going up, especially with the advent of anterior hip replacements and quicker recovery. This is what an X-ray looks like after a replaced hip. So you can definitely tell the difference between right and left. That X-ray would be on a right total hip replacement. And you see that cup sitting in there and the ball sitting in the middle of the cup. It kind of looks like the ball's floating in there, and that's because the plastic liner doesn't show up on X-ray. This is kind of a breakdown of what we previously saw that's just not put in a bone model. The cup, the liner, and the head, and then the stem. And so all those things go together to form a total hip replacement. They're also called total hip arthroplasty. So some specifics about the direct anterior approach. There's several advantages. One of the reasons that I like it is because of the patient position. The standard lateral and posterior approaches have the patient laying on their side. It's more difficult to get an accurate X-ray, and it can create some pressure points. With an anterior approach, the patient's laying on their back. Obviously, the anesthesiologist gives you a nice little map, and we're able to do things from the front. So achieving a very good X-ray, which helps in the implant size, the implant position. It helps us dial in your leg length to make sure that we're getting things, within 0.5 millimeter and extremely, extremely accurate. It's also a very small incision in the front of your leg, quick wound healing. We don't have to cut off any muscles like other approaches. We're able to just move them apart. And that can in turn confer some more stability to the hip. So you don't have the same hip precautions. Typical hip precautions with a posterior approach are bending your knee over 90 degrees, turning your leg in, which are very, very common movements. And those are removed with an anterior hip. So you don't have to worry about that in your postoperative recovery process. Moving on to total knee replacement. This is a slide of a healthy knee and an arthritic knee like we saw in the hip, kind of looking for some of the same things where the healthy knee has nice white cartilage that covers the end of the bone. It also has healthy meniscus that is a shock absorber between those bones. When you get arthritis and that cartilage starts to wear, it also tears up and degrades your meniscus. So your bone now, it no longer has a shock absorber. It no longer has a cartilage covering, and your bone on the femur is contacting bone on the tibia, and that causes pain and inflammation. So that's why people with arthritis not only hurt, but their knees swell. Their body produces more fluid because of that inflammation. And this is illustrated there in the yellow box. So an X-ray of a knee with arthritis and a healthy knee, you can see there on the left that the healthy knee has space between the bones. And that space isn't air, that space is cartilage and meniscus. And so the x-ray goes through that, we don't see it, but we know by having that space there that those structures exist. When we look at the knee on the right, we see that on the inside of that knee, the bone is touching, the bone from the femur is touching the bone from the tibia. And with every step and every bit of flexion and extension of that knee, that's grinding together, causing pain. Kind of an interesting little fact about, pre-surgical weight loss, I think, is important. It's not always imperative that somebody is at a certain weight before surgery, but for every pound you do lose, it takes 4 pounds of pressure off your knee. So you kind of get a 4-for-1 deal, which is always bonus. And then how does a total knee replacement work? A little different from the hip, because a knee is not a ball in a socket joint, it's a hinge joint. So if we're comparing these two slides, it's a partial knee replacement and a total knee replacement. So in a partial knee, we're able to replace one compartment. And there's some slides coming up that'll illustrate that a little bit better. But the 3 compartments of the knee are the inside, the outside, or medial and lateral, and then the patellofemoral, which is underneath the kneecap. So a partial knee replacement can replace 1 or 2 of those compartments in one surgery. A total knee replacement is for a patient who has disease in 2 or 3 compartments, and that replaces all 3 compartments at once. So you don't have any more compartments that are worn out and anything else to hurt. There are about 600,000 knee replacements performed each year. So, double the amount of total hips, and they're continuing to go up in numbers as well. These are some x-rays. On the left there, you have a medial compartment partial knee replacement, or basically just replacing the inside compartment of that knee. That's where there was arthritis, and that takes away all the pain. You can tell in that x-ray there's still space on the outside. So the inside was just replaced. On the right is a total knee replacement, and that's replacing everything. So you have all 3 compartments that get replaced and resurfaced and take away all that pain that was coming from all 3 of those compartments. So one of the techniques that I use when I do a total knee replacement is the MAKO robot. And we'll kind of get into some reasons that I do that and some advantages of the MAKO robot. There's a lot of different ways to do a total knee. I've done them multiple ways, and I found this one to be the most reliable and the most accurate. So what does the robot actually do? I think that, sometimes people think that I go in and push a button and the robot replaces the knee. It's not quite there yet. I wish it would do it. It would make my job a whole lot easier most days. Play this video for just a second.
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the MAKO system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the MAKO system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
Okay, so there's just some extra information at the end of it. She kind of talked you through all that sort of stuff, but I'll put it in my own words a little bit. Basically, what the MAKO robot allows me to do different from a non-robotic knee is from the CT scan, we create a three-dimensional model. And from that model, like you can see there in the pictures, it is not, it's not generic. It's specific to your bone, to your knee. Once we go into surgery and measure the tension of your ligaments, we're able to adjust the implants on a computer screen before they ever go in your body. And so we know that the implants are in a perfect position virtually. And once they're in a perfect position and we know that that balances the knee well, then the robot wheels in and I use the robotic arm to make those cuts. And once those cuts are made, then the implants go in a perfect position. And so it's more of a tool of precision that just allows a very, very well-balanced knee. And a well-balanced knee means a better recovery and a longer lasting implant. So those are my reasons for using it. I'm always happy to, again, answer any questions at the end of this, if it's specific to the robot or just surgery in general. So recovery from joint replacement. That's probably most of the questions that I get from patients that are considering surgery are related to the recovery process, because that's where people's mind goes. The point where they're asleep and they're getting the joint replacement, whether it's a robot or not. Some people really research that, and some people just want it done and then know how long until they're better. That's the question, right? So obviously, the day of surgery is when you get your knee fixed. Typically, people are in the hospital for a night or two. We generally use home health physical therapy that comes out to your house, and they do the postoperative home care and rehab. They get you up, get you moving, kind of a continuation from what they've done in the hospital. The therapist in the hospital will get you up same day of surgery or the next morning to make sure that that knee is starting to bend and you're able to walk, get your balance, go upstairs, those sorts of things. I see people back in my office at 2 weeks, 6 weeks, and 3 months. Obviously, the whole time I've been in communication with home health. I always tell people at 2 weeks, you don't like me very much. Your knee's still hurting you. At 6 weeks, you shake my hand, and at 3 months, you give me a hug. Obviously not literal. Sometimes it is, but it just illustrates the recovery process. At 6 weeks, pretty much everyone is better than they were before they had the surgery. So that 6 week to 3 month part, everything there is bonus and just continuing to get better and better. I do see people back at 1 year, and then we do some semi-annual follow-ups to take x-rays and make sure that the joint's doing well on x-ray. Kind of going through, these are national averages, 1 to 4 days in the hospital. I don't know that I've had anybody stay more than 2, but it's there if it's there if need be. Kind of getting back to daily activities, 3 to 6 weeks. They say 6 to 12 months typical recovery. I think most people in my practice are 90% better at the 3 month mark. But everyone's a little different. Some people are a little quicker, some people a little slower. A lot of that depends just on your preoperative activity level and what kind of physical conditioning you have. So the point of a joint replacement is the potential to get you back to doing what you love. And it really doesn't matter what that is. There's almost nothing that, if you liked doing it before, you can do it after. I do recommend low impact exercises as opposed to high impact. So walking, swimming, cycling, those sorts of things are going to be less stress on that joint than jogging, weightlifting, heavy weights. But I have patients that do all of that, and I don't put activity restrictions on people. I just talk to them about the lifespan of a joint replacement and what they do on that and how that affects the lifespan. And related to that, that's another common question. I'll go ahead and just get it out of the way before somebody asks it. I typically tell people that the expected length for a partial knee replacement is 10 to 15 years. A total knee replacement is about 15 years, maybe 15 to 20. And a total hip is 20 to 25 years. Obviously, those are estimates. You know, the newer technology that we have now has the potential probably to last longer. But those are kind of some historical numbers. And I like to under promise and over deliver, we'll say, on length of time. We can go to some questions now, and I'll just kind of leave this slide up too. There's an email. If you have any questions that you come up with tonight, or you wake up tomorrow morning and you think, man, I wish I would have asked that, you can go ahead and email. That's Caitlin Acosta, cacosta@directorthocare.com, and we can get back to you on that. I'm going to go ahead and open up the questions section. And looks like, let's see, I have questions and I have some comments. So I'm going to try to answer both of them. Okay, one question is, does my insurance pay for this? The short answer is yes. I obviously don't do the billing office stuff. You can ask them. I'm not much of an accountant, but generally all major insurance plans cover total joint replacement. And that's in, you know, if it's medically indicated. And obviously I'm not going to suggest it if it's not. So I can't really tell you the last time that I've had a total knee or a total hip get denied. I don't really have any issues with it. So I'd say at this point, probably about 100% yes. Now, some people have certain out of pockets, et cetera. You know, we don't have enough time to go into all that, but that changes with everybody. The next one, should I be stronger with a joint replacement? They don't really change your muscle strength, but I will tell you that if you have pain in your knees or your hips, people really say that they feel stronger walking upstairs. And it's not that their muscles got stronger. Initially, it's just that their knee or hip doesn't hurt. So that makes a big difference. And if you're not moving because your knees hurt, after you get your knee replacements, your hip replacements, and you get out, you walk more, you're in the garden, you're playing golf, your muscles will get stronger. Do I have to hug you? No, you don't. God bless you, whoever said that. You absolutely do not have to. Is the robot ever wrong? If so, how do you correct it in the operating room? The people at Stryker will probably be mad at me. It's not about that it's wrong, but there definitely is a lot of surgeon input. So I say all the time, the robot is a tool. And if you give a hammer to my 2-year-old son, he's going to break every window in the house because he doesn't know how to use the tool. But if used correctly, with somebody that's done a lot of total knee replacements, it allows you to be much more precise. So I've been using the robot now for 4 years. I started off saying I was going to do 10% of my total knees using it, with the idea that if anything I didn't like, you can always move it out and do it the regular way. I had all the other instruments in there to do it. I've never done that in 4 years, and I quickly went from 10% to 50% to 90% of my total knees within a 3-month period. And now I'm probably at 95 or 96%. There's some random reasons why you can't use it, but it's exceedingly rare. Will doc help with finding out if insurance will pay for this? Absolutely. They take care of all of that. Those are the people that are smarter than me in the billing, accounting, front desk. They take care of all of that. Let's see, how long do I have to do physical therapy? Everybody's a little bit different. I would say the average for hips is about 2 weeks. For knees, it's about 3 or 4 weeks. So most of that gets all the way covered by home health physical therapy. And so there's not any outpatient involved. Occasionally there are some insurance plans that don't want to do home health physical therapy very long. And so those people do go to an outpatient physical therapy setting, which we have at both Doc North and South locations. So that's an easy transition once I see people at 2 weeks if we need to get them into outpatient therapy. Do I have to do surgery at the ER or hospital concerned about COVID? That can depend on some medical problems, but as long as there's nothing outstanding. I have 2 separate facilities, one in particular that I operate at that are surgical hospitals. And that means that there's only surgical patients in those facilities. There's no medical patients. So every surgical patient has been pre-screened for COVID, as well as obviously all the staff and employees. I've had both vaccines and a booster, so 3 shots. So it's about as safe as an environment as you can get right now. I'd like to knock on some wood, but we haven't had any COVID issues at either one of the surgical hospitals, and I plan to keep it that way. Can this procedure be performed on your shoulder? Currently, no. I don't do shoulder replacement, but I'm involved a little bit, just from the robot side of knowing what they're working with. The company is based out of New Jersey, and I know that they've been flying some people in and out working on that. Currently, I don't really have a timeline on it to give you an update. I think it'll be there eventually. Let's see, can I combine this with injections? You do not inject a joint when you replace it. So I always like there to be a 3-month window between an injection and a joint and a total joint replacement. And the reason that is there's pretty good evidence that tells us that 3 months, as long as 3 months have passed after an injection, that the risk of infection returns back to the national average. And so we always want to make sure that there's that gap. So once you get your knee replaced, you don't have to get any more injections. This must be a planted question. Do I get a little doc teddy bear with that? It's not standard. Normally we give it to kids, but all you have to do is ask, and I'm pretty soft, so I would for sure hand one out to you. I've heard that stem cells can help in the recovery. What are my thoughts? I haven't done any stem cells in total joint replacement. Reason being, I don't like to inject around a newly implanted joint because the risk of infection. So that would be my take on injecting anything around a total joint arthroplasty. I do think that stem cells is a very broad term, so you kind of have to be careful on what that means, especially right now. There's a lot of back and forth marketing, but if we're just looking at any type of regenerative injection, I think those can be beneficial in trying to delay surgery and get the longest out of your native joints possible. But once you have the joint replaced, I'm not injecting anything in it. I think I might have made it to the bottom of the list. If anybody has anything else. If not, like I said, that email down there for appointments or questions, anything like that, feel free to write it down. I'll leave it up for just a minute and get in contact with us.